Hello everyone, this is Wael Mohammed. I'm a transplant hepatology fellow at Cleveland Clinic, Ohio, and I'm doing this review mainly for my own education. And I believe, whenever you read a topic and review it, read it very well, understand it, and then try to present it to others, this is the best way to keep it for many years. This presentation might be helpful for medical students, interns, and residents starting their hepatology rotation. Today we're going to be reviewing sclerosing cholangitis, mainly primary sclerosing cholangitis through the AASLD guidelines. Speaking of epidemiology, the incidence of PSC is 1 to 1.5 cases per 100,000. And for prevalence, it's 6 to 16 cases per 100,000 person years. Okay, so let's go over some very important definitions to start with. For PSC, it's a chronic cholestatic liver disease, mostly autoimmune in origin, characterized mainly by inflammation and fibrosis of the intra and extrahepatic bile ducts, leading to the formation of bile duct strictures and frequently associated with IBD, as we all know. And then we have a specific small duct PSC, which is less common variant and characterized by the typical cholestatic and histologic features of PSC, but the bile ducts are completely normal on cholangiography. So you have the cholestatic features and the histologic features, but whenever you do the cholangiography, it's going to be completely normal. Then we have the PSC AIH, the autoimmune hepatitis overlap. And this is like a diagnosis when you have like a concurrent, the dual diagnosis PSC with overlapping AIH. So you'll have the clinical, biochemical, and histologic features of AIH on the biopsy, mainly interface hepatitis. And then for secondary sclerosing cholangitis, this is when you have like biliary strictures, but secondary to specific identifiable causes causing the biliary cirrhosis. But our talk today is going to be focusing on the PSC, the primary type. Then we have the IgG4 sclerosing cholangitis, and this is usually secondary to elevated IgG4 positive plasma cells in the tissues, and there is like elevation of the IgG4 in the serum, and most of the time there is pancreatic involvement. Then we have the dominant stricture type, which is usually a biliary stricture detected on the ERCP, and the specific finding is going to be a diameter of 1.5 millimeter in the common bile duct and or less than 1 millimeter in the hepatic duct. So this is mainly detected on the ERCP. Then you may have the high-grade stricture, which is usually detected on the MRI, MRCP, and this stricture, the specific definition for this, when you find more than 75% reduction in the common bile duct or hepatic ducts. And finally, a relevant stricture is any kind of like biliary stricture of the common bile duct or the hepatic ducts associated with signs or symptoms of obstructive cholestasis and or bacterial cholangitis. So let's review the pathophysiology of PSC. So the suggested theories are as follows. So within the intestine, it all starts in the gut. There is like an altered microbiome causing like inflamed mucosa and impairment of the intestinal barrier, causing leakage. And then the intestinal lymphocytes or the microbial products or the metabolites translocate through the portal vein to the liver, activating immune responses. And then those microbial components or the metabolites from the gut will directly activate the biliary epithelial cells, causing inflammatory responses. And then the peribiliary glands will start like expansion, and in addition to the peribiliary mesenchymal cells, through a hedgehog pathway, acquiring a myofibroblast phenotype. So this myofibroblast activity will cause large duct fibrosis. So this is the main mechanism. So here we have a very, very nice diagram illustrating the pathophysiology of PBC. So it all starts in the gut with, as we mentioned before, dysbiosis with inflamed colonic mucosa leading to gut leakage through the impaired mucosal barrier, leading to immune activation with alteration in the innate and adaptive responses of the body, and then and with impairment of the regulatory T cells. This will cause biliary responses in the form of cholestasis and the activation of the biliary endothelial cells, which causes peribiliary myofibroblast activation, leading to dilatation of the large biliary ducts mainly. Regarding the etiologies of the secondary sclerosing cholangitis, we may have like infectious causes like HIV-related cholangiopathies, that is, one of the commonest causes, or pyogenic cholangitis, maybe parasitic, specially hydrated cysts, echinococcosis, ascariasis, fasciolasis, schistosomiasis. Ischemia might be a cause, especially in the critically ill patients, and malignancy for sure. Cholangiocarcinoma is like one of the examples. Autoimmune in cases of eosinophilic cholangitis or the IgG4 related cholangitis, anatomic or drug induced. And the most common kind of like drug-induced cholangiopathy is immunotherapy, especially the checkpoint inhibitors like the pembrolizumab, nivolumab, and atezolizumab. Okay, so let's start with few guidelines. First of all, regarding the diagnosis, any patient who is suspected to have PSC, the first step is obtaining a 3D MRI, MRCP, with contrast enhancement. This is very important, mainly to evaluate the cholangiographic features of PSC, which are going to be mainly the intrahepatic and or extrahepatic strictures, which are going to be alternating with the normal or slightly dilated segments. Then, in patients with suspected PSC, but they have like normal high quality MRI, MRCP, then we should like consider liver biopsy to rule out small duct PSC. In those patients with an equivocal MRI, MRCP, they should be referred right away to an experienced center for consideration of a repeat of the high quality MRI, MRCP, and possibly obtaining a liver biopsy. And then if the diagnosis is still unclear within a year, you may repeat the MRI, MRCP later on to see if there is like any change from the prior imaging. Many people may think that ERCP is essential for a diagnosis of the PSC, but actually this is not the case. ERCP should be completely avoided for the diagnosis of PSC. PSC is mainly an image-guided diagnosis, and if the imaging is not conclusive, the next step should be obtaining liver biopsy for histological evidence. This goes along with with the cholestatic pattern on um, liver biochemistry. Any patient with possible PSC, serum IgG4 levels should be obtained in order to rule out any possibility of IgG4 sclerosing cholangitis. For a liver biopsy, it shouldn't be performed routinely in patients with typical cholangiographic findings on the MRI MRCP. When to do it? Only and only if there is concern for autoimmune hepatitis overlap. At that time, a liver biopsy might be helpful. Here we have a very nice algorithm navigating the diagnosis and management, initial management or diagnosis of PSC. If you have a suspected PSC patient, after you obtain history and physical exam, then you order serum LFTs or liver tests, and you have the cholestatic pattern of liver biochemistry. Then you should obtain an MRI MRCP. The next step is once you find biliary strictures, this is like a clear-cut diagnosis of PSC. As long as there are no causes of secondary sclerosing cholangitis, so you're gonna consider this as primary. If you have an equivocal result, you should be transferring the patient to an experienced center of evaluation for evaluation, and you can like repeat later on the MRI, MRCP in a year, or as we mentioned before, consider a liver biopsy. If you have a normal MRI, MRCP, then the next step should be liver biopsy. And based on the histologic findings, if they are compatible with PSC, then you are gonna call it small duct PSC. If not, you should consider an alternative diagnosis. In this slide, we have like few images. First of all, we have the MRCP at the top left image showing diffuse intrahepatic strictures everywhere, especially this one with the arrowhead in the main biliary duct showing high intensity structure, high grade structure. In the second one, the lower left image, this MRI is showing there is like enlargement of the caudate lobe relatively if compared to the right hepatic lobe, which is kind of a little bit atrophic. On the upper right image, you're gonna find like there's enhancement of the contrast showing the thickening of the biliary walls, marked by the arrows here. And then finally, the lower right image is showing marked enhancement of the right and left hepatic lobes, unlike the caudate lobe in this image. Back to guidelines. Ileocolonoscopy with biopsies should be performed in patients with a new diagnosis of PSC for sure and no previous diagnosis of IBD. But in patients without IBD, subsequent ileocolonoscopies should be considered at 5 years intervals or whenever new symptoms arise suggesting IBD. So if you have a patient diagnosed already with small duct PSC, if you remember, we diagnosed small duct PSC when we had the cholestatic pattern already there, and then we did the imaging, it wasn't conclusive, and then we needed to do a liver biopsy which showed the histologic findings, and that's how we reached a diagnosis for small duct PSC. Then you should monitor those patients with Q3 to 5 years MRI, MRCP, and mainly this is to screen for or monitor the development of large duct disease. Risk stratification fibrosis staging should be done at diagnosis of PSC and regularly during follow-up. Those clinical risk tools can be considered for this purpose, but specific probabilities of events should be interpreted with caution in the individual patient. So every single patient, we should cautiously choose the appropriate clinical risk tool for assessment. Here are the models we use for classification and clinical risk assessment. We have the Amsterdam Oxford from 2017, the UK PSC from 2019, and the Presto, the PRESTO from 2020, and the Scope 2020 as well. The variables used for the Amsterdam Oxford, or actually it's the end point for this tool is to evaluate for the need for liver transplant or liver-related death by 15 years. And the variables used were age, bilirubin, albumin, AST, alk phos, platelets, and then the subtype of PSC, whether small or large duct. Usually you punch in some numbers and it's gonna give you a score or risk assessment at the very end, and it's calculator based thing. For the UK PSC 2019, they removed the AST and then they added the 1 point for presence of extrahepatic biliary disease and another point for the presence of previous history of variceal hemorrhage. And the end point was to assess short and long-term complication like death or the need for liver transplant by 2 for short term and 10 years for long term. And then we have the Presto. They had the same age, bilirubin, albumin, AST, alk phos, platelets, and then they added the hemoglobin, sodium, and then the number of years since PSC diagnosis. And this is used for evaluation of hepatic decompensation, the development of ascites, variceal hemorrhage, encephalopathy by 5 years. For the Scope 2020, the variables were bilirubin, albumin, platelets. They added the GGT and the cholangiography findings in the form of either large or small duct involvement. And the endpoint was to evaluate the complications from portal hypertension, biliary complications, the development of cholangiocarcinoma, the need for listing for liver transplant, and or death from liver disease by 5 years. This algorithm illustrates or shows you how to choose the clinical model selection. So if you have a patient with no portal hypertensive complications from prior, and we are not going to talk about the child, but for children or pediatric population, but for adults, if this patient is above 18 and he has autoimmune hepatitis overlap, you would rather go ahead and use the Amsterdam-Oxford tool. If the patient has small duct involvement, you can use either the Amsterdam or the UK PSC. And if the patient has a large duct involvement diagnosed with large duct disease, so you are gonna use any of the Amsterdam, UK, or Presto. If the patient has decompensated cirrhosis, you can just go ahead and do the MELD score, the MELD sodium, or actually now it's the MELD 3 score. For every single patient with PSC, you should be evaluating the liver stiffness, and the measurement is usually by the transient elastography or the MR elastography, which is the preferred method for estimation for sure of fibrosis stage in patients with PSC. Is liver biopsy needed for fibrosis staging? Definitely not, but liver biopsy is needed for a different goal, which is usually diagnosing the possibility of small PSC in patient with cholestatic pattern of transaminitis and negative imaging. Then we have a general recommendations that all patients with PSC should be considered for participation in clinical trials. And this is um, usually like a routine at the clinic. Usually we'll have those patients with new diagnosis of PSC. We'll have the coordinator reaching out to them, and then we have our colleagues from the research department will come by to the clinic, talk to the patients about the most recent or active studies, and they offer them the participation, and then they take consents, and then we go from there. This point is super important. In patients who are not eligible or who are not interested in clinical trials and they have persistently elevated alk phos or GGT, then a trial of ursodeoxycholic acid, with a dose of 13 to 23 mg per kg per day can be considered for treatment, and this should be continued if there is a meaningful reduction or normalization of alk phos level, um, and or if the symptoms improve within 12 months of treatment. This is the very, very, very important point. Again, any patient who is not interested in being involved in a clinical trial, those patients should be started on ursodiol 13 to 23 milligram per kg per day. And what's going to be the next step? You continue if there is meaningful reduction or normalization of the alk phos, or there is improvement of symptoms. And then the next question, is there any evidence to recommend the use of oral vancomycin for the treatment of PSC, since the pathophysiology involved some sort of like alteration in the microbiome? So the answer is no, no need, or it's not recommended to start oral vancomycin for treatment of patients of PSC. The next question is going to be, what should I do if I have a concurrent diagnosis of autoimmune hepatitis along with the PSC? Then the management is going to be treating those patients as if you're treating autoimmune hepatitis according to the AASLD AIH guidelines. When should I consider antibiotics? Antibiotics should be used for bacterial cholangitis with consideration of for MRCP to rule out relevant strictures. So antibiotics only in case of development of bacterial cholangitis. So you had a patient with bacterial cholangitis, you started antibiotics, and you haven't noticed or you didn't notice inadequate or adequate response to antibiotics. What should be the next step? The next step should be ERCP. So ERCP should be performed for bacterial cholangitis if there is an inadequate response to antibiotics. When to screen for varices? So you do EGD to screen for varices if you have a liver stiffness more than 20 kilopascal by elastography or the platelet count is below or equal to 150 K. Surveillance for cholangiocarcinoma and gallbladder carcinoma should be performed on annual basis, and you do abdominal imaging, and the best modality is MRI, MRCP, either with or without CA19-9. The surveillance is not recommended for patients with PSC under 18 years of age and those with small duct PSC. No need to do any surveillance. When you do the RCP, you do brushings as well to obtain or do intraductal tissue sampling. This is for cytology and fish testing. Should be done routinely during the RCP for relevant strictures. This amazing algorithm walks you through the steps, starting with diagnosis with MRI, MRCP, and you find the relevant stricture, and you didn't find any masses in those patients with PSC. So when you do the ERCP and you obtain biliary biopsy and brushings, and this is for fish and cytology, based on the results, you're gonna decide the next steps. At the very left, if the biopsy is completely negative, cytology negative, fish negative, then the next step should be obtaining MRI, MRCP in 6 to 12 months intervals. At the very right of the algorithm, if you find a biopsy which is positive and cytology is positive and or cytology is positive, then you had a diagnosis of cholangiocarcinoma. In the middle, if the cytology is suspicious and the fish is negative, you should be repeating the ERCP in 3 months. Similarly, if the cytology is negative or suspicious for fish polysomy, when you repeat the RCP in 3 months, you have like a couple of possibilities. The first of all, if the cytology on the repeat is positive, so this is cholangiocarcinoma, confirmed. If the cytology is suspicious, and the fish is negative, you should be repeating the MRI, MRCP and ERCP in 6 months like before. And if the cytology is suspicious and the fish shows polosomy, this is going to be probable cholangiocarcinoma. Um, it's kind of a little bit complicated, but if you repeat it, the algorithm like by practice, like in like a couple of times, then it's gonna be like more um, understandable. The next question is, when should we consider cholecystectomy? Cholecystectomy should be considered for patients with PSC with a gallbladder polyp larger than 8 millimeter, preferably at an experienced center in patients with advanced disease. But if the polyps were less than or smaller than or equal to 8 millimeter, you may consider monitoring them with ultrasound every 6 months. So do you remember this number, 8 millimeter and larger and bigger? This is going to be cholecystectomy. But if smaller than or equal to 8 millimeter, ultrasound Q6 months. For PSC patients who develop cirrhosis, we can just do the hepatocellular surveillance along with the AASLD guidelines, which is mainly Q6 months ultrasound or any kind of like imaging plus minus alpha fetoprotein. For patients with PSC who had an IBD, an associated IBD diagnosed, we should be obtaining surveillance colonoscopy with biopsies starting at the age of 15, sometimes 18, 15 years, and repeat this at 1 to 2 years intervals to evaluate for any development of colonic dysplasia. When do you do ERCP? For ERCP, it may be indicated for evaluating relevant strictures, the development of new onset or worsening pruritus, any new unexplained weight loss, worsening of the serum liver test abnormalities, any new rising of the serum CA19-9, any recurrent bacterial cholangitis, or any progressive bile duct dilation on imaging. For MRI, MRCP, we should consider that prior to every single ERCP, this is to clarify the need for biliary intervention and guide the technical approach. So it's mainly for diagnostic purposes and to guide the therapeutic ERCP if needed. Those patients who are gonna undergo ERCP, we should start antimicrobial prophylaxis during the peri-procedure period. From therapeutic standpoint for ERCP, the choice between biliary balloon dilation with or without stenting, should be left to the endoscopist's discretion. And in cases, if he decided to go ahead and place a stent, The stent should be removed within 4 weeks following placement. If the patient has pruritus, so bile acid sequestrants should be used as initial therapy for patients with PSC who have pruritus that doesn't respond to conservative measures. So we start with advising the patient to avoid heat, apply some emollients, use antihistamines, but if everything failed, you can start a bile acid sequestrant. Alternatives for refractory pruritus, I mean pruritus who is not even responsive to bile acid sequestrants, should be sertraline 100 milligram daily. That's one option. Another option is naltrexone, and you titrate to a dose of 50 to 100 milligram daily. And finally, you may use rifampin 150 to 300 milligram twice daily. If the patient has pruritus, so bile acid sequestrants should be used as initial therapy for patients with PSC who have pruritus that doesn't respond to conservative measures. So we start with advising the patient to avoid heat, apply some emollients, use antihistamines, but if everything failed, you can start a bile acid sequestrant. Alternatives for refractory pruritus, I mean pruritus who is not even responsive to bile acid sequestrants, should be sertraline 100 milligram daily. That's one option. Another option is naltrexone, and you titrate to a dose of 50 to 100 milligram daily. And finally, you may use rifampin 150 to 300 milligram twice daily. So another algorithm, as we just mentioned, patients with PSC and pruritus, and then those patients who have dominant or relevant stricture obstruction, if they have any of that, you should consider ERCP management right away. If not, so no stricture, no obstruction, then you start conservative measures. Avoid heat, apply emollients, use antihistamines. If there is no improvement, the first line therapy is going to be cholestyramine 4 to 16 gram per day. If no improvement, then the second line therapy should be sertraline 100 milligram per day, or rifampin, or naltrexone, as we just mentioned. If there is no improvement, the third line therapy should be phenobarb 60 to 100 milligram per day, or maybe plasmapheresis or phototherapy. If there is no improvement after all of that, you should consider liver transplant. For IBD management, it's going to be very similar to the regular patient. So it doesn't matter if the patient has PSC or no PSC, it doesn't change anything in management. For surveillance of colon cancer, this should continue even if the patient is already transplanted. You should be still screening or doing surveillance for colon cancer in IBD patients with PSC, even status post-transplant. From nutrition standpoint, nutritional assessments including and not limited to biometrics and lipid-soluble vitamin levels A, D, E, and K should be performed at diagnosis and then annually after that with nutritional intervention and vitamin supplementations as needed. From nutrition deficiency standpoint, again, the fat soluble vitamins A, D, E, K. For vitamin A, as we all know, the symptoms are going to be mainly night blindness, xerophthalmia, and the repletion doses are 5,000 to 100,000 international units daily for 2 weeks, and then you do maintenance by 1,500 to 5,000 international units daily. For vitamin D, those patients are prone to osteomalacia, osteoporosis. You obtain a DEXA, and then you decide based on the score for if the replacement is going to be based on the vitamin D level. If below 12 nanogram per milliliter, you're going to do 50K international units for 8 weeks and 50K weekly for 8 weeks. Then you do maintenance by 800 international units daily. If the level is between 12 to 20, you do 800 to 1000 international units daily, and then you maintain by 800 to 1000 international unit daily as well. If the level is between 20 to 30, you do 600 to 800 as repletion, and you continue the same dose for maintenance. For E, clinical symptoms are mainly neuropathy, ataxia, progressive neuromuscular disorder, hemolytic anemia, and then the repletion is 200 to 2000 milligram daily, and for maintenance just 15 milligram daily. For vitamin K, you may find hypoprothrombinemia, bone disease, impaired osteoblast function, and you replete by 2.5 to 10 milligram daily, and then you maintain by 5 to 10 milligram oral weekly to daily, and you should be monitoring the INR. But generally we just we most of the time we have vitamin D the main issue, and that's what we replete. As we all know, bone density examinations by DEXA scan should be performed to rule out osteopenia, osteoporosis at the time of diagnosis, and then at 2 to 3 years interval based on the risk factors. For bone disease with normal vitamin D levels in patients with PSC, what do? If you find osteopenia, you do vitamin D replacement 2000 international units daily. And for calcium, you do 1 to 1.5 gram per daily. For osteoporosis, if the patient has normal vitamin D, you should be reviewing the previous history. If the patient had no EVs before, then you do vitamin D replacement, the 2000 units, and you do the calcium, the same like before, 1 to 1.5 gram per day, but you add the oral bisphosphonate. If the patient has history of varices, you avoid the oral bisphosphonates and you do it parenterally. This specific point is super important because sometimes you in the pre-transplant clinic, when you evaluate the patient for the need of transplant, then those specific points you should check to see if those patients would benefit from a liver transplant. So liver transplant should be considered in all patients with PSC, and first of all they develop complications of end-stage liver disease, or they have recurrent cholangitis, or they have intractable pruritus, who failed all the previous modalities of treatment for pruritus, as we previously mentioned, and then finally the presence of early stage hepatobiliary cancers. For those patients who received a transplant and then they developed transaminitis, Those patients should have biopsy for histologic and cholangiographic assessment as well, to differentiate recurrent PSC from allograft rejection or the development of any biliary complications. So, to sum up, patients with elevated liver enzymes after transplant should undergo histologic and cholangiographic assessments to distinguish recurrent PSC from allograft rejection and or biliary complications. Shifting gears to cholangiocarcinoma. An elevated CA19-9 alone shouldn't be used to diagnose CCA. Again, an elevated CA19-9 on its own should not be used to diagnose cholangiocarcinoma. So what do I need? I'll need a histopathological confirmation in order to obtain a definitive diagnosis of cholangiocarcinoma or intrahepatic cholangiocarcinoma. Imaging is very important. So cross-sectional imaging of the liver, like obtaining a multiphasic CT or MRI, is required in order to facilitate the assessment of primary masses, vascular invasion, presence of intra or extrahepatic metastases, and resectability. Then we will need a CT, chest and abdomen in order to stage the disease. This is very important step, the staging. Do I need a PET scan? No. A PET scan should not be used for diagnosis of primary tumor in cholangiocarcinoma cases. So, what's gonna be the management? The management is mainly surgically. So surgical resection is the treatment of choice for patients with a single intrahepatic cholangiocarcinoma nodule in a resectable location. This is very important, a resectable location without evidence of metastatic disease and who have adequate functional liver volume. So those patients to be considered for surgery, they have to have a resectable location, no metastases, and adequate functional liver volume. It's always advised to have those patients who are diagnosed with the intrahepatic cholangiocarcinoma to be referred right away to a center with surgical expertise in hepatobiliary malignancies. Adjuvant capecitabine should be considered for all patients with no diagnosis of cholangiocarcinoma. Liver transplant for the unresectable liver limited intrahepatic cholangiocarcinoma should only be considered under research protocols. So data are insufficient to recommend loco-regional therapy as a standard therapy for locally advanced unresectable intrahepatic cholangiocarcinoma. So still TACE and those kind of treatments. There are no sufficient data to recommend those as a good option for the locally advanced unresectable type of intrahepatic cholangiocarcinomas. CTs or cross-sectional imaging and cholangiographic studies are required in patients with suspected perihilar cholangiocarcinoma or the distal type for assessment of the tumor extent along the biliary tree, identification of mass lesions, contrast enhancement, and vascular encasement. ERCP with biliary brushings for cytology and fish analysis should be obtained in patients with suspected perihilar and distal cholangiocarcinomas. This point is very important for the perihilar cholangiocarcinoma. An EUS-guided fine needle aspiration or percutaneous biopsy of a perihilar mass should not be used for diagnosis. Why that? Due to the risk of tumor dissemination precluding liver transplant. If liver transplant is not an option, then EUS-guided fine needle aspiration can be diagnostic. So again, no EUS-guided fine needle aspiration or percutaneous biopsy for those with intention to have a transplant done. If there is no plan for LT, then you can do the EUS-guided FNA. So if the patient with PCCA or DCCA is going to undergo a resection, it's always advised to do biliary drainage, endoscopic biliary drainage of the remnant liver, like preoperatively. So again, in patients undergoing resection for perihilar cholangiocarcinoma or distal cholangiocarcinoma, preoperative endoscopic biliary drainage of the remnant liver is recommended if biliary obstruction is present. Surgical resection is the treatment of choice for early stage PCCA and DCCA without any evidence of metastatic disease. So just surgery with resection. Like before, patients diagnosed with PCCA, DCCA should be referred to a center with surgical expertise in hepatobiliary malignancies. Liver transplant following neoadjuvant therapy should be considered for patients with PCCA, those with less than or equal to 3 centimeter in radial diameter that is unresectable or arising in the setting of PSC. At that time, you may consider liver transplant. In patients with proximal cholangiocarcinoma being evaluated for liver transplant, EUS-guided final aspiration of regional lymph nodes should be performed to exclude patients with metastases before neoadjuvant therapy is initiated. So this is the first point. The second point is that operative staging after completion of neoadjuvant therapy and before the liver transplant is needed to assess regional hepatic lymph node involvement and peritoneal metastases. Systemic chemotherapy is the first-line treatment of advanced CCA. Gemcitabine, cisplatin is the standard of care for newly diagnosed patients. So what if I had the patient on gemcitabine and platinum based chemotherapy and then the patient still had a progression of the disease? At that time we should consider the second line therapy, which is FOLFOX. So upon progression on gemcitabine and platinum chemotherapy, the combination of FOLFOX is appropriate second line therapy. So first line GemCis, second line FOLFOX. NGS, next generation sequencing, should be considered at diagnosis to guide second line treatment options. And then finally, the same recommendations like before. Patients with advanced CCA should be considered for referral to a center with expertise in hepatobiliary malignancies and available clinical trials. And that concludes my talk on PSC. Thank you so much for listening and see you later.